At this point, I'd like to introduce Pat Long. She's been a volunteer working with Caring House since the very beginning. And as I mentioned before, that's been a number of years we've been working on this. But anyway, Pat Long.
We are very fortunate today because we have Claire Tehan, and I want to tell you just a little bit about Claire. She's our keynote speaker, and if you want to know a lot about Claire, on the back of the program that's on the table is her resume. But for now, you can listen to me. So, Claire has been active in the hospice movement in the United States since 1975. She started when she was 1, I think, or something like that. And she was instrumental in the development of the original national hospice standards, of the hospice Medicare regulations, of the California hospice licensure, and numerous educational initiatives. Claire is a frequent presenter at state and national conferences on hospice all over the country. Locally, Claire is known as the founder and past CEO of Trinity Care Hospice. Also, personally, she has lived in the South Bay. She's married for 40 years now to her high school sweetheart, and they've raised 2 daughters, Nina and Monica. And when Claire doesn't have anything else to do, which is probably never, she does yoga, she does gardening, and she swims daily. And I just heard she just started sculpting. She said, so please welcome this amazing woman, Claire Tehan.
Thank you, Pat. Only half of it's true. You figure out. Very happy to be here this afternoon and to see such a great turnout. And Bill, you mentioned you've been at it a long time. I know. I remember many years ago when you and Ed first came and started talking to me about this when I was at Trinity Care Hospice. So I'm delighted to be part of the effort today. I have a short amount of time because we want to make sure that you get out in plenty of time. So what I thought I would do is talk today about where we are today and where we will be tomorrow relative to care at the end of life. And to recognize that where we are today has been shaped by political, social, and economic forces. And in particular, I want to start by talking about the foundation of hospice care and 3 remarkable women. And so let me start in 1967 when Cicely Saunders opened St. Christopher's Hospice in London, England. She was a nurse, then got training as a social worker, and realized that if she wanted to accomplish her goal of creating a haven, a special place for people who were dying, that she needed to become an MD, which she did at age 39. St. Christopher's was a holistic approach to care for the dying, and her approach to pain management was revolutionary. And I have to emphasize that in 1967, physicians did not want to ever use narcotics, when in fact it was demonstrated that narcotics was the most effective pain management for a fair number of patients. They also, as she introduced the regular administration of pain medication around the clock. Back then, people used to wait until the pain was out of control, ask for medication, then you'd get, your medication. And so she attacked 2 things in particular and made a huge difference in how people lived at the end of their life by having their pain managed. She said, I didn't set out to change the world. I set out to do something about pain. And in fact, she did change the world. Let me talk about Dr. Elizabeth Kubler-Ross, another unbelievable woman who has impacted everything about care at the end of life. In 1969, she published On Death and Dying. And that book really took death out of the closet, if you would. And it outlined the 5 stages of grief. Her research was based on interviews with about 500 patients who were dying at the University of Chicago Medical Center. But what's the story behind the story is that when she started looking into and wanting to explore the needs of people who were dying, she went to her colleagues at the University of Chicago Medical Center and said, I would like permission to interview your dying patients. Are there some patients you could refer to me? There were no dying patients at the University of Chicago Medical Center, as per the doctors. This was prior to 1969. That's how much death was denied. Her book was a plea for home care instead of hospital care for dying patients. Here she was in a major medical center, and nobody was admitting that people were dying because hospitals were focused on cure, and dying patients represented the ultimate defeat for physicians, for the hospitals, for the staff. And I'm sure many of us remember routinely visiting dying patients who were placed at the end of a hallway, the furthest from the nursing office, if you will, from the nursing station. That book revolutionized how dying patients were cared for. And, you know, that those 5 stages of grief really today stand as a pretty darn good primer on understanding not just grief of a dying patient, but of loss and grief for any number of things. One other remarkable woman, Florence Wald, in 1968 left her position as dean of the Yale University School of Nursing to work with Dr. Cicely Saunders in England. She returned to Connecticut and chose an interdisciplinary team from Yale University to conduct research and learn more about the needs of terminally ill patients. They went on to found and open in 1971 the Connecticut Hospice, which started out as a home care program and ultimately created a freestanding facility. So 1971, the first hospice in the United States. In the process of developing this hospice, she made nurses an integral part of the care of patients and forged a new coalition between physicians, nurses, and patients, replacing the long-held tradition that the doctor reigns supreme. The core idea of this group was that when hope for cure is gone, attention should shift to the dying patient's physical, emotional, and spiritual comfort. 1976, Hospice of Marin, Northern California, became the second hospice in the United States and the first in California. Happy to say, proud to say that in 1977, Trinity Care Hospice, known then as Hospital Home Health Care Agency of California, began caring for patients in the South Bay, establishing itself as an earlier provider of hospice care. And I'm really proud to see so many alumni of Trinity Care Hospice / Hospital Home Health Care in the audience today. I think that what is important to recognize about the hospice movement up until the early 80s is that it was a monumental volunteer effort. And many hospices had entire volunteer staff. And it was an incredible community replicated around the country of people recognizing that people at the end of life needed far more than what they were getting from the traditional healthcare system. And what we talked about then in the early days was quality of life, emphasizing that. It's not about the quantity, the number of days, but the quality of the life that we have. And I think what's sort of too bad in what has occurred over years is that in most people's minds now, hospice equals death. And I'll talk about how that shows up in terms of how short a period of time most people receive hospice care. But let me talk about a few more defining moments of the hospice movement and as a path to where we are today. In 1978, 26 hospices, including Trinity Care Hospice, were chosen by the federal government to be part of a hospice demonstration project to assess the cost effectiveness of hospice care. You have to recognize there was no real reimbursement. That's why I said volunteer effort was key, community support was key, because Medicare didn't pay for hospice at that point. Ultimately, in 1982, Congress created the hospice Medicare benefit. And I'll never forget, it was the joining of forces of Senator Dole and Senator Kennedy that introduced that legislation and carried it through and passed the hospice Medicare benefit, which meant that now people who were providing this care could get paid for it. And so what happened, obviously, is that hospice began growing across the country. Because in 1982, there were still, maybe a couple hundred hospice programs, if that. I think another defining moment in hospice was the AIDS epidemic in the early 80s. And at that point, hospice primarily cared for just cancer patients. We had tremendous expertise in caring for cancer patients, and all of a sudden, people with this strange disease that we didn't know much about were being diagnosed and dying very quickly. And Trinity Care Hospice stepped up right from the get-go and forged partnerships and relationships with AIDS providers, with AIDS houses. And so Trinity provided the care in the home, and the home provided the room and board, etc. Again, a model somewhat of what we're talking about with Caring House in terms of working different entities working together to provide for people at the end of life. Today, not only are there over 5,000 hospice programs in the U.S., increasingly, hospitals are recognizing that the care of patients who remain in the hospitals and are dying in the hospitals can benefit from palliative care. So we're seeing palliative care consultation teams, palliative care programs arise as well. Without getting into the details of it, suffice it to say that palliative care is slightly broader than hospice. Hospice is palliative care to relieve symptoms, pain of the illness, and yet hospice has some restrictions because we get money from Medicare, and they say needs to be a prognosis of 6 months or less. But nonetheless, I think the point is that we've come a long way. In 2010, for which we have the most recent data, 42% of all patients who died in the United States were cared for by hospice. 1.58 million people received hospice services in 2010. That's a 162% increase in 10 years. So the need is there. The proof, obviously, is in the people who are seeking, choosing, and accepting hospice care. I think that the challenge is that as I said earlier, hospice equals death in most people's mind. About the median length of stay, the time at which somebody receives hospice care, is at 19.7 days, okay? So although Medicare defines hospice as approximately the last 6 months of life, people are receiving hospice care for a very short period of time. And there's a lot of reasons. I mean, we don't want to admit sometimes what's happening in front of us. Physicians still have a sense of failure oftentimes when somebody is declining, and there is still a tremendous avoidance of talking about caring as opposed to curing. And interestingly enough, only 36% of the patients served on hospice today are cancer patients. So hospice care and care at the end of life, we recognize, goes well beyond cancer patients, but people with end-stage chronic illnesses are appropriate and receiving hospice care. So what are the challenges and opportunities ahead of us? It's obvious. The population is aging. The baby boomers every day join the ranks of over 65, and it's going to continue. So too, obviously, are the number of people who need an alternative like Caring House. Let's talk for a moment about the kind of people who might need a Caring House. You and me. Patients who live alone but have no one to care for at the end of life. Families, as Bill mentioned earlier, who have served as caregivers and are unable to continue at the end. You know, they may have been taking care of their loved one for months, weeks. It's exhausting, it's draining, and they just can't do it any longer. I consult with hospice programs around the country, and many of them have residences for people at the end of life. And this is what I have seen or heard from those families. They talk about the comfortable surroundings, staff that are there around the clock, a home-like experience. We can enjoy each other's company. It's a gift to be a daughter, a grandson, or spouse, and not the caregiver. A peaceful place, unencumbered by the outside world. Community, the sense of being with people who are in a similar situation, and the community and the support that evolves. Serenity, tranquil, sense of calm and peace. Those are some of the quotes from people that I've spoken to. And so, as we talk about Caring House and think about those adjectives, those words, that sense that is possible. Because so many people have said that they never would have chosen this particular experience, but what evolved, what happened, what came together for people at the end of life was some of the most meaningful time of their whole lives. I'd like to conclude with a quote from another remarkable woman, Margaret Mead. "Never doubt that a small group of thoughtful people can change the world. Indeed, it's the only thing that ever has." And so my hats are off to the people who have been working on this concept, on this idea of Caring House, because they are a group of thoughtful people who are really trying to change our world here in the South Bay. Thank you.